my topic is kind of less controversial and will be kind of enlightening, encouraging for all the specialities. Now we are dealing with drugs to prevent progression of CKD and diabetes and heart failure. All of them have a propensity to increase potassium. I'll be discussing how to deal with that. So before starting with that, in the era of evidence-based medicine, what I say is absence of evidence is not evidence of absence. So today, what is absence of evidence, tomorrow there will be evidence. So it's not equal with evidence of absence. We all know that hyperkalemia is defined as potassium more than 5. So it's very common in patients with reduced kidney function from all sorts of GFR, starting from stage 1 to stage 5, progressively increasing. And of course, with the management medications that we frequently use for treating chronic kidney disease, hypertension, diabetes, heart failure, RAS inhibitors. And there is metabolic acidosis, which actually perpetuates and aggravates the effect of hyperkalemia in chronic kidney disease, in renal dysfunction. So in general population, if incidental hyperkalemia is 2 to 3%, advanced CKD with treatment on RAS inhibitors with diabetes mellitus, the effect is almost 20 to 25 fold the prevalence of hyperkalemia. Severe heart failure with mineralocorticoid receptor antagonist up to 40%. Hemodialysis patients were sort of inadequately dialyzed, the incidence of 25%. Itself, diabetes mellitus, even without renal dysfunction, there is incidence of 17% hyperkalemia, and resistant hypertension without diabetes and with on MRA therapy, the tune is around 20%. So hyperkalemia is very prevalent in the subpopulation of the disease that we treat and discuss today. So what is the risk of hyperkalemia? It is bad actually. If you discuss in the patient of CKD, non-dialysis patient, with the risk of death in CKD is 5 times more if the potassium is more than 5.5 but less than 6. But it crosses 6, the risk of death is 16 times more. And in case of a patient with hyperkalemia with acute myocardial infarction, the risk of death is respectively 5 times and 12 times if the potassium is between 5.5 and 6 and more than 6. So it is detrimental. You need to be very, very cautious about the patients having hyperkalemia, potassium more than 5.5 and 6, and treat them emergently. So, of course, as the GFR decreases, the incidence and prevalence of hyperkalemia increases. From stage 1, the relative risk from 1, and the stage 5 is almost 10 to 11 times more common to have hyperkalemia in these patients of CKD. So hyperkalemia is associated with increased risk of hospitalization. It's been seen that it's almost 4 times higher in patients with CKD and almost 3 times higher in patients with heart failure. The patients with hyperkalemia, if we understand in our clinical practice also, if we see a patients with hyperkalemia and CKD, frequently if we see ECG changes, we get them admitted, almost 2 to 3 days of admission and using various medication to lower down the potassium to normokalemia, and we discharge them. But is it enough? No. The problem is we do not see for recurrent hyperkalemia. If a patient with a risk factor has a hyperkalemia and hospital admission, the patient is more prone to develop recurrent hyperkalemia. And the incidence of hyperkalemia increases after every event. After first event, the risk of second event increases, third event increases, and so on and so forth. So the important thing is, it's not enough to treat hyperkalemia as a solitary event. You need to monitor the patient more carefully once the patient has got 1 episode of symptomatic or ECG proven hyperkalemia, and you need to keep the patient on more close follow-up because this is going to recur and create problem. So RAS use, we understand the hyperkalemia is increase in patients with cardiorenal patients with RAS use. With no CKD to stage 5 CKD, the prevalence of hyperkalemia increases almost logarithmically. The case is almost similar in patients with CKD and no CKD. But patients, what happens if you have a hyperkalemia and you discontinue CKD or discontinue RAS inhibition or reduce the dose of RAS inhibition in a suboptimal dose, the patient who discontinue or receive suboptimal RAS inhibition has actually adverse outcome across different stages of CKD, heart failure, diabetes, and in total population also. If you discontinue or use suboptimal use of dose of RAS inhibition, your actual mortality benefit is going to be low. So potassium, high potassium is not allowing you to give the benefit of use of RAS inhibitor to your patients. So what do? Are you optimally managing the patients with hyperkalemia? Are you stopping or changing the RAS inhibitor? Or are you treating the hyperkalemia suboptimally, or are you doing nothing? Just taking notes and you're following up the patients. So despite guideline recommendation to optimize RAS inhibition, the majority of the patients on CKD and heart failure remain below target doses. The causes are multifactorial. One of the causes is hyperkalemia. The patient is developing hyperkalemia and not use a full dose. So no full dose, no full benefit. Definitely, they have a dose-dependent benefit, this RAS AC inhibitor, the RAS inhibition. Again, the risk of acute worse deterioration of the GFR. The GFR decrease, you stop and decrease the dose of the RAS inhibition. So it's kind of a knee-jerk reaction, and it's always the AC inhibitor or the ARB or the middle cortical receptor antagonist to blame. So these are the main pillar of treating your disease, your CKD, your heart failure, diabetic kidney disease, but they are taking the majority of the toll of having a increase in creatinine or decrease in GFR or increase in potassium. You have knee-jerk reaction, you stop that or forget about that. I will not use that. Let's be safe. But you're forgetting the benefit of prolonging the life, treating the CKD, treating the heart failure. So hyperkalemia is a barrier to the maximum RAS inhibition dose. 1 in 3 patients on RAS inhibition had more than 1 episode of hyperkalemia, more than 5 during a median follow-up of 3.4 years in this study. So following a hyperkalemic event, RAS down titration and discontinuation occurs in 38 to 47% patients as from different spectrum of hyperkalemia, mild to severe. So when patients who require RAS inhibition develop hyperkalemia, what do? What is to be prioritized? Keep the patient on guideline recommended RAS inhibition despite risk of chronic recurrent hyperkalemia, or reduce hyperkalemia risk by discontinuing RAS inhibitors. There is always a dilemma. Along with this dilemma, in advanced CKD, there is a dilemma of decrease of the GFR. Creatinine বেড়ে যাচ্ছে, potassium বেড়ে যাচ্ছে, দেবো কি দেবো না? So RAS inhibition discontinued. Simply, it's been seen that the mortality risk actually doubled in susceptible group of patients, CKD with advanced cardiovascular disease and having diabetes. So RAS down titration and discontinuation associated with increased risk of morbidity in cardiorenal patients. There is no doubt about this. RAS inhibition stopping or decreasing is detrimental. So guidelines emphasize RAS optimization, monitoring the hypokalemia, treating the hyperkalemia, and only after measures have failed, you think about reducing the dose or absolutely discontinuing the agent. So all sets of KDIGO, CKD guidelines, 22, 21, ESC heart failure guidelines, they have always recommended to use the maximally tolerated dose of RAS inhibition to have the maximum mortality benefit on this chronically progressive disease. But the barrier becomes hyperkalemia. So only few patients are retested following a hyperkalemia. I told you earlier, somebody who is having a hospitalization or symptomatic hyperkalemia will have a recurrent hyperkalemia because the pathophysiology, the drugs mostly have to be continued. And patients with CKD and diabetes receiving RAS therapy may benefit from the regular potassium monitoring. So what are the agents we have to treat emergency treatment of hyperkalemia? They are being divided into 3 categories: the cardiac stabilization, the redistribution of the potassium, and actually lowering the potassium. Calcium gluconate, we know, do not have the capacity to reduce potassium. It only stabilizes the cardiac membrane and prevents arrhythmia to happen in face of hyperkalemia. Insulin dextrose, acetylcholine, beta-adrenergic agonists, they redistribute potassium from extracellular component to intracellular component for a short time being. Again, the aim is to reduce the cardiac abnormality, the cardiac side effects, namely the arrhythmias, the fatal arrhythmias, the best measure to quickly reduce potassium is dialysis. I mean, dialysis can take out the potassium from your body and is extremely effective without any doubt, and it acts within minutes. You start dialysis, potassium starts coming down. So what are the other drugs other than dialysis that can reduce potassium burden from your body? Definitely diuretics. But remember, diuretics will act only when the GFR is significantly preserved. The patient with a GFR of 15 or less than 15, diuretics are not only agent that are going to take care of your hyperkalemia, taking out potassium. Dialysis, yes, I already discussed. The most commonly used agent that we frequently use is a resin, sodium polystyrene sulfonate. We give it orally, powder, dissolve in water, take 3 times. After meal, it binds to the potassium that is free in the gut and it gets excreted in the feces, does not get absorbed. The thing is, the onset of action is 2 hours. The effect lasts for 4 to 6 hours. You have to give frequent dose. The GI tolerability is very bad. The patient usually have acidity or vomits or have diarrhea or commonly have constipation or bloating. They have serious side effects like intestinal necrosis, and they can lead to absorption of sodium and fluid retention, which is not good in a patient who is having CKD or heart failure. So not the ideal agent. Once you think about using this ACE inhibitors, ARBs and MRAs for a long term, very long term use of this sodium polystyrene sulfonate is not been seen to be useful or beneficial or tolerability aspect for this kind of patients. Low potassium diet is recommended only starting from stage 3 CKD. Discontinuation of RAS inhibition is a bad option that we do not want to discuss. So we come to newer agents. Today we shortly discuss this agent that is being available and FDA approved from last 2015. Now it's going to get available in India. Sodium zirconium cyclosilicate is a non-polymer inorganic compound which acts as a potassium exchanger in the gut. It's extremely effective. It's been seen in harmonized trial that it takes at least as early as 2 hours to reduce the potassium to less dangerous level, and within 48 hours almost all patients had normokalemia. The most important thing is that the tolerability of the drug. This drug, even used for a very long time, is being very well tolerated. GI tolerance is very good as compared to the conventional sodium exchange resin that we use. This study has data up to 1 year when the patient has been given sodium zirconium cyclosilicate along with RAS inhibition and MRA. The potassium remained low. Even they have used the standard doses 5 to 15 grams. They have used even alternate day, 5 grams alternate day without any major GI side effects. The patients are being maintained on normokalemia even on the face of using an MRA and ACE inhibitors and ARB. So majority of the patients continued RAS inhibitor therapy while taking AZC, sodium zirconium cyclosilicate for hyperkalemia. 74% of the patients were able to continue the previous dose, or some of them were even able to increase the dose in face of hyperkalemia and continuous use of SZC. It's usually safe. Patients were evaluated in clinical trials to establish SZC safety. 507 patients received SZC for 1 year. 5.7% of the patients developed some amount of edema, which is usually easily treated. 4.1% of the patients reported hypokalemia that resolved with the SZC dose adjustment and discontinuation. It does not affect the serum level of calcium and magnesium. Why it's important? I'll tell you if you have a time for discussion. We have a competitive molecule known as Patiromar. Patiromar is not going to get available in India. That's why I'm not discussing. Again, these two agents, Patiromar and SZC, are available in other countries in the US, been FDA approved from 2015. SZC is not absorbed or metabolized by the body, and there is no expected effects on the medicinal products on the pharmacological actions of SZC. SZC can transiently increase the gastric pH, so you have to use the drugs either 2 hours before or 2 hours after. So hyperkalemia is an ongoing threat. If you need to use the RAS inhibition and MRA, you need to use one agent that you're going to be used continuously without major effects on tolerability and GI side effects. For rapid potassium reduction and sustained potassium control, AZC is good therapy, and they are now trying AZC as the first anti-hyperkalemic therapy to deliver data on the cardiorenal benefit from the crystallized trial. The results will be going to be available soon. That is the end of my topic. Thank you.